Thank you very much. The controversy, there's a great deal of controversy in the United States, still is, it kind of periodical, but Europe hasn't been nearly as controversial, with the possible exception of UK, and part of the story is we're learning in the United States from Europe. So I keep telling people the sun rises in the east, and we get information from Europe that helps us in resolving some of this controversy. Financial disclosure, I own a company that designs clinical trials for companies and cooperative groups. So 1997 was sort of the beginning of the controversy, with a consensus development conference at the NIH that I co-chaired, that came out with some statements that were viewed as being anti-screening mammography, and this indicates in Newsweek the hate mail I had received, including death threats. In 2010, subsequent to the 2009 U.S. Preventive Services Task Force statement that essentially agreed with the 1997 statement, in part because there had been very little information, certainly from randomized trials, over that period, and continued the war and the so-called brawling. It was a highly politicized issue. The Senate at one time during this process voted 98-0, essentially mandating that screening mammography would be effective for women in their 40s, sort of like playing God, if you will. Lessons from the mammography wars. Advocates, particularly radiologists, took immediate action denouncing the Preventive Services Task Force statements, suggested that this was government rationing at the time with Obama's health care. The suggestion was that these were death squads, and this is one more death squad. Even implying the panel members were guilty of a callous disregard for life and well-being of women. This is a quote from the Washington Post, Daniel Copans from Harvard. Tens of thousands of lives are being saved by mammography screening, and these idiots want to do away with it. It's crazy, unethical, really. Now, some of you, English is not your native language, certainly not United States English, so I thought I would define this word for you. This is a word that if you're ever in a marriage spat with your spouse, you never use this word. Because if you do, it means the relationship is over. You can't apologize afterwards for having used this word. This is probably the worst derogatory expression in the English language, and to use it in the Washington Post against an academic council is really astounding. Fundamental screening principles, these are not patients, these are people, ordinary people that are regarded as at risk of having something, but they're otherwise healthy. Decision must balance uncertain benefit with clear harms. I say clear harms. Most of the downsides of screening mammography are certain. The upsides are less certain. There are lots of biases, lead time bias, length bias. I can't get into it in my time. Suffice to say that the only way around them is to do randomization, which people have done, as you know, in the randomized trials. So I want to talk about the randomized trials and maybe give you a different perspective on them. In screening, there are very few that benefit, even if the sensitivity of the test and the specificity of the test are huge. The positive predictive value is still tiny. In screening mammography, it's less than 1%. and so most of the positives are false positives. There's an artificial benefit of screening that's important for clinicians. I think most of you are clinicians. The breast cancer you see today is completely different from the breast cancer from the pre-screening era. And that, the prognosis is a good deal better. And that sort of convinces physicians that, boy, this screening is good. But there's an artificiality to the goodness. There's lead time where you're getting the thing earlier in its disease, and so the period of time between when you detect it by screening and when it would have been symptomatically detected, that's a time that you're looking at the patient when you wouldn't normally be looking, and so the patient lives during that period of time. Patients are living longer and longer, in part because of treatment, in part because of the potential for screening to be beneficial, but in part because of these biases. Length bias is even more insidious. When we find a cancer, we find disproportionately cancers that are slowly growing. They have a long sojourn time. It's like when you take a potato chip from a bag of potato chips, you're more likely to get a bigger chip. So you're more likely to get a longer sojourn time, and that is a cancer that is less likely to kill the patient. That leads to having method of detection as a factor in trials. There's a famous trial in the United States called TAILOR-X, looking at the benefit of Oncotype DX, that we've now learned, and that trial has, as a factor that we're collecting, how was the cancer detected? Because it trumps lots of other things, including the most important prognostic factor in early breast cancer, namely nodal status. So this is an editorial, screening mammography paradox: better when found, perhaps better not to find. So the randomized trials, Nystrom in 2002 published an update of the Swedish trials, a very nice meta-analysis, in part to address concerns from the Cochrane Collaborative. There are 18 years of follow-up. He did two analyses. One was a so-called evaluation analysis, another a follow-up analysis. It's a subtle difference. The Swedish trials, most of them had a period of screens in the screening group and a final screen several years later. The control group had no screens, but at the time for the last screening in the screening arm, the invitation to screening arm, was to be a control mammogram. Now, unfortunately, the control mammogram slipped. And in some cases, it was like 14 months after it was supposed to be given that the control mammogram was given. And then they were going to count only those cancers that occurred during the period up until the last mammogram. This slippage meant that they were counting in the control group cancers that they wouldn't have been counting in the screening group. So I objected to that, and in part because of that, Nystrom did a follow-up analysis, drawing the line chronologically rather than in terms of when the last mammogram was given. And the follow-up analysis had less of a benefit expected, as was expected, a 15% reduction in mortality as opposed to 20% reduction. So these are the data that he published, and in the 40 to 49-year-old age group, the evaluation analysis had a 19% reduction. The follow-up analysis had only a 9% reduction. These translate, and I do this for Kaplan-Meier curves or curves like this. I look at the area between the curve to get a measure of absolute difference. The absolute difference in this case is per woman for the evaluation analysis 2.7 days. So the typical woman gains an average of 2.7 days. Of course, there is no woman that gains exactly that. It's like a lottery where this is the average. And the follow-up analysis is 1.3 days. So we're not talking about huge benefits. In 50 to 59, 3.2 days versus 2.6 days. In 60 to 69, where the benefit is really substantial, 32% versus a 27% reduction, the benefits are in the order of a week per woman. This is the effect of age. In the evaluation analysis, there seems to be a slight tendency to have more effectiveness with older patients, but it's especially clear in the case of the follow-up analysis, where the benefit is very clearly on the older women, the women especially 60 and older. There is this thing down here in the corner. There were not too many women were older than 70 in the Swedish trials, and the control arm actually did better, but I think this is a statistical fluke. Adding other countries, Canada had a study in the 40s, study for women in their 50s, and showed very little benefit. They were smaller studies. I've added them here. In the interim, since the 2002, the Sue Moss's age trial in the UK was announced with a 17% reduction. I've added that here. So if you combine them, you get, for the younger women, like a 10% reduction, and older women, a 24% reduction. And the results are reasonably consistent across the countries. Benefit of early detection. So this is something in this, I indicated in this editorial. Does this make sense? Does something like 10% make sense in terms of percent reduction? So think about the course of the disease. The doubling, the initial cell, the doubling, maybe the body gets rid of it at some point. But at some point, many of these cancers become evident. So there's doubling up until the time you can actually start to see it. And at roughly the 27th doubling, you get the ability to see on a mammogram. Of course, you may not see it on a mammogram, but it's big enough to see it. And by the time it's 2 cycles later, 2 doubling cycles later, it's typically clinically manifest. Now, of course, sometimes, even when it's clinically manifest, you can't see it on the mammogram for dense breast, for example, but this is sort of typical. Now, suppose, the question is, when does the tumor become metastatic? Suppose it becomes metastatic before it's detectable by screening, so roughly 27 doubling cycles. Screening is too late. The cat's out of the bag. The tumor's out of the breast and into places where it's going to be potentially lethal. Suppose it's after the 29th cycle. Then, of course, it doesn't matter because you've already found, screening doesn't matter because you've already found the tumor. So it's only in this interim, it's only in like 2 doubling cycles out of 29 or 7% where screening potentially has the benefit to change something from metastatic to not. So the 7% is in the same range as the 10%. These are not huge potential benefits. So the challenges for us, for you, is to decide which tumors are metastatic, something that we're not very good at. We're getting better at, obviously, with biomarkers. We know that 20% of breast cancers are lethal, but we don't know which ones. We don't know when they become lethal. We don't know which ones we can ignore. We sort of expect that we can ignore more that are ER positive, HER2 negative, luminal A, but we don't know for sure which ones of those. We don't know which patients are cured by surgery, and we don't really know what the role is of prevention. To try to relate the mortality reductions in the RCTs, I did the following. I said, suppose you're bicycling in cities. Cities not quite so bad as Houston, but other cities, say in UK or in Europe, wearing a helmet. The savings is about the same as bicycling for 10 hours. Canceling a 20-hour bicycle ride when you plan to wear a helmet. Losing an ounce or two of body weight and keeping it off. These things don't go over well when I tell people this. They say, you know, they're trying to minimize the effect, but this is real. Marcia Angel in the New York Times suggested that the results were so small that at this age, that the risk of driving a car to get them might well outweigh the benefits of the test. That's actually not true unless you're driving for a very long distance. But if you're motorcycling or bicycling or walking, then it probably is true. So I have some risks of screening here, and you can get my slides and go over them. I do want to say a little bit about overdiagnosis, because it seems to be the thing that has captured the imagination of many researchers today. It's a very knotty problem, a very difficult problem to address. There are some minor harms. Gil Welch and Bill Black in JNCI addressed overdiagnosis in cancer and concluded that about 25% of mammographically detected breast cancers are overdiagnosed, including invasive cancers as well as DCIS. This number is very controversial. There are others who say it's 50%. There's some who stand by essentially 0% is overdiagnosed. So it's something we were asked by the task force to address this question, and I sort of gave up coming up with something that I could hang my hat on. There clearly is overdiagnosis. Exactly how much is not clear. So you can see here in the Swedish trials the large increase and no compensation in terms of coming back to, you sort of expect there to be an increase, but then you expect there to be a decrease afterwards. And so far that doesn't happen in the randomized trials or more generally. These are data from the United States and SEER, and there's a suggestion that at least some of this in terms of incidence is overdiagnosis. So the recommendations of the task force were for women in their 40s to the decision to start regular biannual screening should take an individual circumstance into account, including the patient's values, but not necessarily mandate screening mammography. There was a suggestion in the task force that you needed to screen 1,900 patients in the 40s as opposed to 1,300 patients in the 50s. And Otis Brawley of the American Cancer Society said the task force is saying mammography saves lives, just not enough of them. It's a difficult problem, this is my interpolation of what they said, to draw the line. Where do you draw the line? Do you draw the line here or back here? And it has to do with trade-offs, and I think the individual woman suggestion is the good one. I'm not going to talk about CISNET because I don't have time, but CISNET contributed in several ways. It's a cancer intervention and surveillance modeling network contributed in several ways to the task force. First, in regards to the women in their 40s. Second, in regards to the biannual versus annual. The randomized trials didn't address that question. And third, and perhaps most importantly, updating the results of the trials that were conducted mostly in the pre-chemo, even pre-tamoxifen era, to the current circumstance where there's therapy. And do the effects of screening still maintain in the current era? And we concluded essentially yes. But I'll let you look at the rest of my slides to see how that came about, but I'll stop there. Thank you.
Thank you for that provocative look. We